Yes, absolutely. I would like to thank the chairs for the introduction. I am very grateful and honored to speak first in today's session, though it feels a bit high pressure, as approaching sarcoidosis treatment in Vietnam makes it sound like I'm an expert. In reality, I am not an expert, but I have followed a few patient cases and would like to share my experiences with them. Well, as you all know, pulmonary sarcoidosis is a chronic inflammatory disease characterized by the formation of non-caseating granulomas, which can affect multiple organs, with the lungs being the most commonly involved, accounting for 90% of cases. The causes of sarcoidosis are still unclear, but there are some theories suggesting it may be a reaction of the body's immune system interacting with environmental factors. Regarding the epidemiology of sarcoidosis, global research reports an incidence rate ranging from 2 to 60 cases per 100,000 population, and it is commonly found in people of African American or Northern European descent. The commonly affected age group is 20 to 40 years old. However, it can occur at any age, and in Vietnam, we do not yet have studies reported to tell us what the epidemiology of sarcoidosis is like in our country right now. But personally, I have found that since I started paying attention to it, it seems I have encountered quite a few cases that I might have previously mistaken for tuberculosis or thought were lung tumors. So, in the context of Vietnam, which is a country with a high burden of tuberculosis, sarcoidosis, especially pulmonary sarcoidosis, is a disease that can easily be misdiagnosed as TB. And the treatment decision for this disease will depend on many factors related to the progression of lesions in the organs, as well as the impact of those lesions on the patient's symptoms and quality of life, or the potential risks of functional decline or life-threatening dangers that dictate the treatment decision. And there are quite a few cases of sarcoidosis that can spontaneously regress, especially the forms found in cases where the patient only has mediastinal lymph nodes, where the regression rate can reach 70 to 80%. However, in cases with lung lesions, the rate of regression will be lower. And because of that, it poses a series of challenges in Vietnam regarding diagnosis. Because the symptoms are non-specific and easily mistaken for other diseases, especially tuberculosis infection in Vietnam, it can lead to delayed diagnosis, and the progression of the disease over time will need to be monitored, and the decision to treat will also depend on the disease's progression. But we will also face a challenge, which is whether our patients will return for us to monitor them, or if we will lose them to follow up. And when indicating treatment, issues related to the side effects of medications for this disease are also a matter we need to consider. So, within the scope of this presentation, it mainly addresses the issue of approaching sarcoidosis treatment. However, last year, I also presented a paper on the diagnostic approach to sarcoidosis. So, for diagnosing sarcoidosis, 3 factors are required. These include appropriate clinical contexts pointing towards sarcoidosis, symptoms consistent with findings on chest X-rays and lung CT scans suggesting sarcoidosis lesions. Then, the clinical symptoms of sarcoidosis can be said to be non-specific. Perhaps the patient has no symptoms and is just having a checkup, only to accidentally discover bilateral symmetric hilar lymphadenopathy on a chest X-ray. Or, there are cases presenting with symptoms like a persistent cough, or initial symptoms like uveitis, blurred vision, or skin lesions. In Vietnam, the cases I have encountered are usually discovered accidentally on chest X-rays showing mediastinal lymph nodes, or I have also encountered cases where patients go for a checkup and discovery of lung lesions. Initially, we suspect it might be tuberculosis, but it turns out to be sarcoidosis. Besides high-resolution chest CT scan images, in cases with lung lesions, the suggestive imaging findings are lesions distributed along the bronchovascular bundles, concentrated in the central hilar regions, or in the peripheral lung parenchyma, distributed along bronchovascular bundles, or interlobular septal thickening, and so on. And for the diagnosis of sarcoidosis, besides suggestive symptoms on X-rays and CT scans, it is very important to exclude diseases that may have similar manifestations. Especially in Vietnam, we need to differentiate these cases from tuberculosis. Next, for conditions where patients have very large mediastinal lymph nodes, we also need to differentiate them from malignancies like lymphoma. And in many cases, histopathological biopsy will suggest the diagnosis with findings of non-caseating granulomatous inflammation, featuring numerous granulomas of uniform size. As for current recommendations regarding the diagnosis and treatment of sarcoidosis, it can be said there are not many. First, in 1999, there was a consensus recommendation from the ATS, IAS, and the World Association for Sarcoidosis and Granulomatous Diseases. Then in 2019, the BTS released a guideline on sarcoidosis management, and ATS 2020 provided a guide on the diagnostic approach to sarcoidosis. And recently, the IAS 2021 released a guideline on the treatment approach for sarcoidosis. In Vietnam, we do not have a dedicated guideline specifically for sarcoidosis management. However, in the recommendations for diagnosis and treatment of interstitial lung disease issued by the Vietnam Ministry of Health in 2023, there is a section on sarcoidosis included within it, and it has been covered in relatively detailed terms regarding diagnosis and treatment issues. So, when do we need to treat pulmonary sarcoidosis? As we know, not all cases of sarcoidosis require treatment, as treatment is based on balancing benefits and risks. It can be seen that research indicates that over 70% of pulmonary sarcoidosis cases do not require treatment because the condition can resolve spontaneously or remain stable. However, there are also about 25% of cases that are at risk of progression and require intervention, and those are cases where patients have clinical symptoms that affect their quality of life. Patients have manifestations where progressive lesions cause a decline in lung function, with a decrease in gas diffusion, or a reduction in forced vital capacity, FVC, or total lung capacity, TLC, or when monitored, the patient shows a rate of decline over time, with a reduction of over 10% in TLC or FVC, or a reduction of over 15% in DLCO, or a reduction in SpO2 of over 4% during exertion or at rest, or PaO2 below 70 mm of mercury with progressive lesions on CT scan of the lung parenchyma, or the patient has pulmonary hypertension, or has lesions manifesting in other critical organs such as the eyes, cardiovascular system, hypercalcemia, prolonged fever, fatigue, and so on. Regarding the treatment approach for sarcoidosis, the top treatment choice remains glucocorticoids, with a preference for prednisolone. For patients, particularly those at high risk, showing impaired lung function, or risks affecting functional decline or survival, the initial prednisolone dose is typically 20 to 40 mg daily, maintained for at least 4 to 6 weeks. If there is a good response, the dose should be tapered by 5 mg every 2 to 4 weeks, aiming to maintain the lowest effective dose of less than 10 mg daily for at least 6 months. However, about 1/3 of cases will relapse and require retreatment. High-dose corticosteroids are indicated for patients with acute progression in vital organs, such as the nervous system, eyes, or rapidly progressive lung lesions causing respiratory failure. The role of ICS remains unclear at this time. A few clinical trials show it may improve mild respiratory symptoms, such as chronic cough, serving as an alternative to a low dose of prednisolone at 5 to 10 mg daily. And, of course, when treating with corticosteroids, we must monitor for long-term side effects associated with the use of this medication. For the second-line treatment approach, when corticosteroids are ineffective, when the patient is corticosteroid dependent and cannot taper to a low dose, or when the patient experiences side effects from corticosteroids, the next option is immunosuppressive agents. Among them, methotrexate is considered a top priority second-line option because of its good efficacy and low risk of side effects. Methotrexate can be used alone or in combination with glucocorticoids, even from the start for high-risk cases, to reduce the corticosteroid dose early and avoid prolonged high doses. Next, drugs such as leflunomide, sulfasalazine, or mycophenolate will be used if the patient is intolerant to methotrexate or if methotrexate treatment fails. Then, the third-line option, in cases where immunosuppressants are ineffective, is to choose immunological treatments like TNF-alpha inhibitors. When using these immunosuppressants, it is especially necessary to monitor the blood count and liver function periodically, as well as to have tests to assess the risk of liver damage in patients using them. That is, testing for viral hepatitis B and C before treatment. Regarding methotrexate treatment, studies show it is effective in about 40 to 60% of cases, with clear efficacy after 8 to 12 weeks of treatment, and effectiveness will be assessed after 6 months. The starting dose can begin low at 5 to 7.5 milligrams per week, administered orally or via subcutaneous injection once a week for patients intolerant to oral intake, gradually increasing to a maximum dose of 15 to 25 milligrams per week. It is necessary to monitor liver and kidney function and blood count periodically every 1 to 3 months, and kidney function every 3 to 6 months. This is a summary of the drugs for treating sarcoidosis, based on the 2021 ERS recommendations, but since time is limited, I will not cover the details. This covers the dosage for each drug, the side effects, and recommendations for monitoring. And this is the flowchart guiding the treatment approach for sarcoidosis from the European Respiratory Society. Accordingly, for cases of pulmonary sarcoidosis, we divide them into a subgroup of low risk, without symptoms. So here, typically, groups presenting with mediastinal lymphadenopathy but without symptoms will be chosen for monitoring, and the patient needs to be followed up and evaluated in the future to assess the possibility in case treatment becomes necessary. And for those patients at moderate risk, patients who have it, however, without a decline in respiratory function, the first-line choice may be treatment with corticosteroids. After that, we monitor, and if there is no good response, we will opt for immunosuppressive drugs. And for the high-risk group, those with lung damage, particularly scatting stage 3 and stage 3, and cases with decreased lung function as mentioned in the previous slide, the treatment approach is glucocorticoids with a starting dose of prednisolone 20 to 40 milligrams, monitoring and adjusting the dose to evaluate the response. And if, in case there is no response or it is not possible to reduce the corticosteroid dose, then we will combine it with immunosuppressive drugs, with methotrexate being the primary one. Next are the drugs as I mentioned before. And the 2025 UpToDate has also provided a flowchart to monitor the treatment approach for pulmonary sarcoidosis patients, which is also based on subsets. Groups of patients who are asymptomatic and do not belong to the groups with diffuse lung damage, symptoms of pulmonary fibrosis, or decreased lung function, then these groups will be chosen for monitoring. For the moderate risk groups, meaning patients have clinical symptoms but also without significant decline in lung function, have pulmonary parenchyma damage, perhaps scatting stage 2 or stage 3, then low-dose corticosteroid treatment may be chosen. And for the high-risk group with declined lung function, the approach is to combine methotrexate right from the start with corticosteroids to allow for early corticosteroid dose reduction, and this is the guidance from the Vietnam Ministry of Health in 2023, which is the Part 1 have also presented previously. We can view it on public online. Supportive treatments for pulmonary sarcoidosis include treating involvement in other organs like the eyes, heart, nervous system, or joints, preventive treatment for osteoporosis due to corticosteroid side effects, as well as flu and pneumococcal vaccinations, and pulmonary rehabilitation. An antifibrotic treatment with nintedanib was mentioned in a BTS guideline, but it was not included in the Gilene, and it is based on results from the INBU-ILD study, in which there were sarcoidosis patients with rapidly progressive fibrotic lung damage. In this group, it was only about 3%, including 20 sarcoidosis patients. It was shown that for these patients, using nintedanib can help reduce the rate of decline in lung function based on FVC assessment. And finally, for end-stage sarcoidosis patients with severe pulmonary fibrosis complications, severe pulmonary hypertension, and no response to medical treatment, lung transplantation may be considered. And in a review in the European Respiratory Journal, in the New England Journal recently, in 2020, A flowchart was provided to approach treatment in cases where patients have interstitial lung disease with progressive pulmonary fibrosis, with criteria for diagnosing rapid progression. For sarcoidosis cases with rapid progression and progressive pulmonary fibrosis, after optimizing immunosuppressive treatment with no response, and there is still functional decline and progressive fibrotic damage on imaging, antifibrotic treatment may be considered. However, as I mentioned, this has not been included in the recommended guidelines because there is not enough current evidence. Regarding routine follow-up for sarcoidosis patients, whether they are untreated or treated, we must monitor the patient's progression. For untreated patients, we must monitor the progression of their clinical symptoms and organ damage to determine when treatment is necessary. For patients who need treatment upon diagnosis, monitoring is essential to assess their response to the medication, allow for adjustments to the regimen based on that response, and track any side effects during treatment. I would like to present a few clinical cases where I have had the opportunity to follow patients over a long period. The first case is a 39-year-old male patient. This patient works in business and has no exposure to environmental dust or pollution. However, he does have a 5-pack-year smoking history and quit in November 2023. In 2013, the patient experienced symptoms of lower back pain and weight loss. At that time, the patient had no cough or fever. He went to the National Lung Hospital for a CT scan of the lungs, which diagnosed mediastinal lymphadenopathy and mediastinal lymph node tuberculosis. According to the patient, he was treated for smear-negative lymph node tuberculosis for 11 months. After treatment, the patient's weight returned to normal, and he did not return for a follow-up examination. In 2021, the patient again developed symptoms of coughing up white phlegm, without fever, chest pain, or difficulty breathing, and went to the National Lung Hospital. A follow-up CT scan of the lungs showed lung parenchyma lesions and mediastinal lymph nodes. Sputum tests for tuberculosis, AFB, were negative, so a transthoracic lung lesion biopsy was performed on the upper right lobe, which resulted in a granulomatous inflammatory lesion suggestive of tuberculosis, and the patient was treated with a tuberculosis regimen for 12 months. After completing the treatment, the patient did not return for a follow-up visit and stated they did not have a follow-up chest X-ray. In November 2023, the patient developed a persistent dry cough, which later produced white sputum, and experienced one episode of coughing up blood mixed with sputum after coughing excessively. They had no fever but complained of chest tightness, shortness of breath, fatigue, and widespread lymph node swelling, including in the neck and groin. The patient then went to the National Lung Hospital for a follow-up examination. At that time, the patient underwent a lymph node biopsy, specifically an excision of a groin lymph node. The histopathology results diagnosed a granulomatous lesion, suggesting sarcoidosis. However, because the patient had been diagnosed with and treated for tuberculosis multiple times without improvement, followed by recurring lymph node swelling, they later came to see us. So, in December 2023, the patient came to us for examination during a phase where they had a prolonged cough and had coughed up blood once. Clinically, the patient had bilateral cervical and groin lymph nodes. However, the nodes were all small, under 1 centimeter, soft, and mobile. Lung auscultation revealed scattered wheezing and rhonchi bilaterally, and SpO2 was 98% on room air. The patient was not in respiratory distress. Regarding the patient's basic tests, since their chest X-ray showed interstitial lung disease, which upon closer review appeared to be bronchovascular distribution lesions, along with bilateral mediastinal lymphadenopathy, we ran a panel for autoimmune diseases given the recurring nature of the illness. The anti-dsDNA test was negative. The patient had also underwent a bronchoscopy at the National Lung Hospital, which showed infiltration in the left bronchial mucosa. A biopsy in November 2023 suggested granulomatous inflammation leaning towards tuberculosis, but the lymph node excision diagnosed sarcoidosis. Tests for tuberculosis and fungi in the bronchial washings were negative. The patient's eye examination was normal. Well, the respiratory function test at that time indicated a suspicion of restrictive ventilation disorder, with an FVC of 57%, TLC of 69%, and decreased lung diffusion with DLCO at 42% and KCO at 99%. Quantiferin was negative. These are the histopathological images from the patient's inguinal lymph node and bronchial mucosa biopsies. I'm sorry. And here is the patient's chest X-ray from 2021, where we can observe diffuse bilateral interstitial lung lesions. At this time, the patient had been treated for tuberculosis, a recurrent tuberculosis treatment. However, at that time, the evidence for TB was negative, and 2023 was when the patient came to see us. The lung lesions were similar, and there were widened bilateral hilar regions. The lung parenchyma lesions tended to progress and increase. And this is the patient's CT scan from 2021 when they were diagnosed with TB lymphadenitis with negative AFB. In November 2023, the patient developed symptoms of hemoptysis. So here are the patient's lung lesions. At that time, we also saw many interstitial lung lesions distributed along the bronchovascular bundles, and a very large lesion in the upper lobes of both lungs. There were some fibrotic areas, and there were also many mediastinal lymph nodes. Then, we re-examined the specimens at Bach Mai Hospital, and the result was suspected non-caseating granulomatous inflammation, looking like sarcoidosis. We consulted within the Interstitial Lung Disease Board. At that time, the diagnosis was stage 2 pulmonary sarcoidosis. Because the patient had both lung lesions, mediastinal lymph nodes, cervical nodes, and inguinal nodes, the patient was initiated on treatment with Medrol 16 mg, 2 tablets a day. Starting from December 2023, clinically, the patient improved well, and by July 1, 2024, when the patient returned for a follow-up, their respiratory function had improved significantly, and clinically, the patient's coughing symptoms had resolved. FVC increased from 57% to 67%. And at that time, we reduced the dose of Medrol to 24 mg per day. Following up on the patient, the clinical progression and lung CT scans continued to improve well. However, the patient developed side effects from the corticoid, manifested by facial swelling, severe acne, and the patient complained of significant epigastric fullness, belching, and then we assessed that the patient's clinical condition was progressing well. This is the scan from November 2023, and this is from February 2024, after 4 months of treatment. Then, in June 2024, we reduced the corticoid dose, Medrol, down to 6 mg per day. Before that, it was tapered down. And then, the patient was followed up for a re-examination on June 26, 2024. I apologize, this is the time of the dose reduction checkup in June 2024. The patient was clinically progressing well, and due to complaints about medication side effects, we reduced the patient's Medrol dose to 4 mg per day and scheduled a follow-up in 3 months. However, the patient was busy and did not return for a follow-up until February 25, 2025, meaning from June 2024 to February 2025, they came back to see me. At that time, the patient was clinically stable, had no symptoms, and was not restricted in strenuous activities. The patient was still walking for 1 hour every day. And at that time, when taking a follow-up lung CT scan in February 2025 compared to June 2024, it was found that the patient's lung lesions began to progress and increase, and lung function also declined, with FVC decreasing from 67% in February 2024 down to 55% in February 2025. After that, we further consulted on this patient in the Interstitial Lung Disease Council, and the council decided this was a case dependent on corticoids and experiencing side effects, so it was decided to add methotrexate. I have added methotrexate to this patient, gradually increasing the dose, and currently, the patient is taking a dose of 15 mg per day and responding well clinically. I scheduled a follow-up, and the patient's lung function improved upon retesting, increasing from 55% to 66% FVC. I scheduled the patient to return for a follow-up in 2 months to take another chest CT scan. Regarding this clinical case, we have a few points to discuss. The patient was diagnosed with tuberculosis twice before. We wonder if those previous TB diagnoses were accurate or actually misdiagnoses, as there was no bacteriological or microbiological evidence in either case. When the patient presented in 2023, the lung scan showed lesions similar to 2021, but they had worsened during the TB treatment in 2021. In this case, we believe it is necessary to follow up with the patient and conduct a multidisciplinary team consultation to reach a consensus on the diagnosis and management plan. The patient responded very well to the follow-up treatment. However, when the glucocorticoid dose was reduced, the patient began to relapse, and long-term high-dose use puts the patient at risk for side effects. Therefore, it is necessary to counsel the patient that this is a chronic disease and explain the importance of close monitoring to adjust treatment. For this patient, according to the up-to-date monitoring flowchart guidelines, it is recommended that patients with high-risk lesions start methotrexate in combination with glucocorticoids immediately to allow for an early reduction in the glucocorticoid dose and avoid side effects. In this case, our initial approach was to use corticosteroids first, and after monitoring for 6 months, the patient responded well, but tapering the dose failed, so we added the medication. Perhaps for cases like this, we should combine methotrexate from the start instead of using corticosteroids alone. For the second clinical case, I apologize that there isn't much time left, so I will report very quickly. This is a patient who first came to see me in 2019. The patient went for a health checkup, had a high-resolution CT scan of the lungs, and incidentally discovered diffuse bilateral interstitial lung lesions. At that time, I only thought it might be tuberculosis, perhaps miliary tuberculosis, and the patient had absolutely no clinical symptoms at that time. Lung function tests were completely normal. The patient still practiced yoga for an hour a day and could jog continuously for 10 kilometers without getting tired. So at that time, I had the patient undergo tests for tuberculosis, a bronchoscopy, but the TB workup was negative, and the quantiferin test was also negative. After that, the patient got busy and did not return for a follow-up visit. Until May 2020, about 7 months later, the patient returned to see me, and their interstitial lung lesions were still stable. However, and there were no clinical symptoms. Lung function tests, TLC, and DLCO were normal. At that time, I suggested the patient be hospitalized for diagnosis, but the patient was busy with work, so they couldn't come in. And until September 2020, which was 1 year after the initial lung lesions were discovered, the patient developed a dry cough 10 days prior. Upon returning for a checkup, a follow-up HRCT scan showed increased lung lesions. I requested the patient to be hospitalized to undergo diagnostic investigations again. Well, after that, the patient underwent diagnostic investigations again, and this time, a systematic series of tests were done, including a workup for autoimmune diseases like ANA, immunofluorescence, RF, and anti-CCP. Then a bronchoscopy was done again, along with a bronchial spur biopsy. The tuberculosis workup was still negative. After that, we held a consultation, first within a panel for a class on interstitial lung diseases, where the professors suggested that this is most likely sarcoidosis. Comparing the images, the lung lesions are indeed distributed along the bronchovascular bundles. This was the 2019 film. The patient had diffuse interstitial lesions like this, but was clinically asymptomatic. In May 2020, those same interstitial lesions showed a slight tendency to increase, and in September 2020, the lesions became denser. This is the histopathology from a transbronchial biopsy of the patient's right lower lobe, showing a small granuloma with only epithelioid cells. Afterward, we presented this patient to the Interstitial Lung Disease Board. The professors diagnosed it as suspected stage 3 pulmonary sarcoidosis. The patient was asymptomatic with stable lung function at the time, so we only monitored and considered treating with erythromycin for diffuse bronchiolitis, but the patient did not improve. During follow-up from September 2020 to February 2021, the patient still had sporadic dry cough, and a repeat chest scan showed significant progression of the lung lesions, while lung function tests showed TLC decreased from 99%. From 4.61 L, it dropped to 97%, but the DLCO, which was initially normal, dropped to only 69%, meaning the patient had impaired gas diffusion. So we reconvened with the Interstitial Lung Disease Board and decided to treat with a moderate dose of corticosteroid, starting with methylprednisolone 32 mg. During follow-up, the patient showed a very good clinical response, and we gradually tapered the dose. We continued tapering the methylprednisolone until we reached 8 mg, and planned to reduce to 6 mg, while the patient remained clinically stable. However, a follow-up chest scan showed the lung lesions were progressing, so we consulted with the Interstitial Lung Disease Board again. At that point, the patient also developed symptoms of fluid retention and acne, so we still had to consider tapering the dose. We convened in a multidisciplinary team meeting for interstitial lung disease. The conclusion was that this patient has sarcoidosis, is corticoid dependent, and cannot reduce the dosage due to side effects, so it was decided to treat with combined methotrexate. However, this is a young, unmarried female patient who wants to have children, so we waited until she finished her studies before starting treatment. And currently, the patient has been on methotrexate treatment for 6 months, and follow-up imaging shows stable lung lesions. Clinically stable, the patient has no symptoms, and the chest CT scan shows the lung lesions are also stable. I apologize for running over time, but this is a third clinical case that we diagnosed 6 months ago. 6 months ago, the patient was admitted due to an infected bronchiectasis condition. Also, a CT scan coincidentally revealed numerous mediastinal lymph nodes. I apologize that I don't have the imaging for this case. We treated the infected bronchiectasis and scheduled a follow-up visit. After 6 months, the mediastinal lymph nodes remained but did not progress or increase. So, at that point, we made the decision to biopsy the patient's mediastinal lymph node lesions. We performed an EBIS TBNA on a station 7 lymph node, and the results showed granulomatous inflammation without caseous necrosis, with giant cells. TB tests from the node aspiration were negative, as was the TB workup from bronchial fluid. Following the treatment approach, we still diagnose this patient as follow-up for mediastinal sarcoidosis, which is stage 1, and we are monitoring them. In conclusion to my presentation, pulmonary sarcoidosis in Vietnam is a disease that can easily be misdiagnosed as tuberculosis or coexist with tuberculosis. Therefore, it is essential that we have a guideline for the diagnosis and treatment approach for pulmonary sarcoidosis in Vietnam, as well as clear guidelines on how to differentiate it and how to approach treatment for patients co-infected with tuberculosis. And it is always necessary to coordinate with a multidisciplinary team to ensure the most accurate diagnosis possible, reach a consensus on the diagnosis, place the patient under monitoring, and educate the patient to understand their disease and actively participate in its management. Regarding treatment, we only treat when the patient has clear clinical symptoms, and glucocorticoids remain the first-line choice with a good response. However, for patients with lung lesions or reduced lung function, perhaps we should combine with methotrexate from the beginning to avoid using high-dose corticosteroids for too long and to allow for an early reduction of the glucocorticoid dose. Monitoring the disease progression is very important so that we know when to make treatment decisions, as well as to monitor the response to adjust treatment appropriately and avoid side effects. That is all from me. Thank you, teachers.